Excellent. It is an honor to present our speaker today. Dr. Nnenna Mbabuike completed her medical education at New York University Grossman School of Medicine and her residency training at the Tulane Ochsner Neurosurgery Program here in New Orleans. She then completed a 2-year endovascular cerebrovascular fellowship at the Mayo Clinic in Jacksonville, Florida. In 2021, she co-founded the American Society of Black Neurosurgeons and served as the president of this society from 2022 to 2023. And with that, I will turn it over to Dr. Mbabuike. Welcome and thank you for sharing your time with us.
Thank you. Thank you for that introduction. Thank you to the Department of Bioethics for having me here today. I'm going to share my screen. Okay. Are we able to see my screen?
Yes, we can see it.
Very good. So again, thank you for having me here today. I'm hoping to take you through a dynamic lecture that I give from my perspective as a neurosurgeon regarding equity. A pretty hot topic now, but hopefully by the end of this lecture, you realize that it is not something that is just trending, but it's something that is vital to our healthcare system if we are going to have a healthcare system that truly takes care of the patients that it serves. So I have no disclosures. Again, today the objectives will be to describe the history of inequity and bias in our society, describe impact of inequity and bias on social determinants of health, and identify the way inequity influences our workforce and the patients who receive those healthcare resources. And by the end, define the value of advocacy in medicine. If there are any questions, please let me know by raising your hand, or we can wait till the end of the lecture. So as was mentioned in my introduction, my background is colored by the places that I've been. And here you have some various images of those places. City College of New York up in our upper quadrant here, Tulane University, NYU, and Mayo Clinic. I did receive my BSMD from Sophie Davis School of Biomedical Education and the School of Medicine. Did my neurosurgical residency at Tulane Ochsner Department of Neurosurgery. And then I did a cerebrovascular in the vascular fellowship at Mayo Clinic. All of that culminating in where I am now at Ascension St. Mary's of Michigan, where I'm a cerebrovascular endovascular neurosurgeon. With that title, I do cases that vary in cranial cases in general, but my subspecialty of cerebrovascular endovascular is my true passion. And so I will take care of patients like this who a 40-year-old came in with an acute onset of left-sided weakness, found to have an acute stroke. What you're seeing here is an angiogram demonstrating an arterial injection into the artery, and what you can see is an abrupt cutoff here. And after an intervention called a thrombectomy, I was able to come into that artery. You can see the catheter here and open up that blood vessel and mitigating the signs of stroke for that patient. In addition, I do cerebral aneurysms, cerebral arteriovascular malformations, all vascular lesions of the CNS system, like this patient who presented with an unruptured middle cerebral artery aneurysm that you can see here again on the angiogram, and then postoperatively it's gone after you see these intraoperative pictures of the aneurysm itself and then after clipping. So while I'm doing these intricate procedures that I'm passionate about and I spend long hours trying to perfect, why is it important in the field of neurosurgery or medicine at large for me to discuss diversity, equity, and inclusion with you today? And that's simply that we don't live in a vacuum. As humans and as part of society as a whole, we are subject to the same biases that affect the inequitable distribution of resources in the world. It's sort of silly to think that all these things that are happening outside stop at the door of our emergency rooms or our hospital doors. The acceptance of inequity as a problem should be followed by the creation of tangible resolutions. To understand the why, we have to understand how we've arrived at this moment, what timeline of events have contributed to the creation of institutions like medicine that have become reflections of bias we see in our everyday lives. Once accomplished, we can, as leaders in neurosurgery and in medicine at large, begin to create a more equitable field. You may be asking kind of what is this moment? This moment that has been created that has resulted in talks like these becoming more popular and more prevalent within medicine comes to the perfect storm of 2020, which we'll get to, where the public health crisis of inequity and bias came to a head. So how does the lack of DEI show up in healthcare? The issue of bias affects those who practice medicine, as well as those who benefit from its services, patients. A lack of diversity, in turn, affects the lens in which healthcare is administered and distributed, albeit unintentionally, creating chasms in the way different populations access and receive care. So those first two patients that I showed you, a patient with an acute stroke who presented and a patient with an aneurysm, the way that it shows up in my practice is that that patient with the stroke may not have been able to access that intervention or the ability to have that stroke intervention. If they did not have that stroke intervention because of their lack of access to an actual hospital that does this intervention, a lack of education as to what the signs and symptoms of stroke are, this is a patient who would then have had a devastating neurological deficit, taking them out of the workforce and upending their socioeconomic status, which then contributes to the lack of equity in healthcare access. Additionally, bias affects the diversity of the workforce, the recruitment and retention of historically excluded minorities, and their subsequent advancement into leadership positions. This is going to become important as we talk about this later, but this retention of historically excluded minorities and subsequent advancement into leadership positions will eventually be what is going to change the way in which we approach equity in healthcare by changing those who are talking about it from positions of influence. So often having a talk like this around surrounded by diversity, equity, and inclusion is uncomfortable for a lot of people. It's uncomfortable for people who consider themselves maybe privileged, maybe feeling the brunt of why there is inequity or bias within medicine or in society at large, and becomes a conversation of blame versus responsibility. One of the biggest challenges in discussing implicit bias and inequity is shifting the conversation centered around blame and centering it on responsibility. Often we focus on the fact that we ourselves may not be biased consciously, that we ourselves, especially as physicians, as advocates for patients, we treat the patient no matter what background that they come from, no matter their race, no matter their gender. However, while we may not be the perpetrator of inequity and exclusion individually, we have a responsibility to acknowledge it still exists and the role it may play in the lives of us as professionals and the lives of the patients we serve. So those patients who are still subject to that bias in society before they get into your clinic, before they come into your ER, are still having to deal with the effects and manifestations of that bias. And if we turn a blind eye because we're not responsible for that, or it didn't start with us, it doesn't allow us to continue to address the inequities that ultimately then result in healthcare disparities. So the historical timeline of inequity and bias is important to understand, as I mentioned, in order to understand how we got here and then understand how we can move from the place that we're at. Implicit bias is a form of bias that occurs automatically and unintentionally. It nevertheless affects judgments, decisions, and behaviors. Implicit bias is something that is not something that we think about. It is affected by the images we've seen as we grow up, that we see throughout society, that we see on our televisions and our media. and unintentionally that is perpetuated in the decisions and judgments that we make about the people that we see around us. These implicit biases within society then result in a kind of priming of how we perceive the world, how we perceive others in it, and then how we perceive that judgment. This is a kind of chart from the National Council on Equity that shows this chart where implicit bias, and as we'll go forward, leads to history, policies, and practices that inevitably lead to inequitable outcomes and racial disparities. So those priming and those associations can be just as simple as the images that we see as we grow up about who looks wealthy, who looks like the most successful people in our society, what we think different races represent as a whole. Implicit bias cannot be fully understood within the society of the United States without understanding where that comes from. A lot of the disparities that we have within our socioeconomic system are racial disparities that are reflected in the way in which different people have been treated in this country, and then therefore what their experience has been going forward. We see here a timeline of implicit bias that has really colored the history of civil rights in the United States, especially when it comes to Black people, slavery, segregation, and then in this new era that we live in this free era. However, not understanding that the civil rights movement, that slavery, that all of these still play a role in the way in which we see Black people as a race, and then their subsequent issues that occur in socioeconomic disparities within healthcare, education, would be turning a blind eye to the origin of that bias and would not allow us to then understand how we can overcome that. The bias that we have in this country doesn't just go towards racial disparities, it goes towards gender inequality. And we see that as in the history of the United States, as the gender gap continues to persist, whether it be in the wage gap in education, as you can see here, the gaps in leadership positions for women of color, the gap in the women who, how we have experienced violence. 1 in 3 will experience violence in their lifetime. 1 in 3 are lost work due to childcare needs, but make up 70% of healthcare workers globally. Annual earnings still lag behind those of white men. Representation by a corporate role, you can see in this bottom corner, you can see still white women and women in general still lag behind white men. Other images of our bias, a major bias within our country is how we see immigrants, how we see others who are not like us, a desire to other people by making them feel like they are the reason as to why things are not going well, why their jobs are not here. All of this results in biases that we have when we see someone come in, maybe to our hospitals, maybe into our schools, who is Mexican, who is Arab, who is something that they have already decided based on media, television, and the implicit bias that exists in society as to who they are in our society. So these associations that we then create from young, as youth into our adulthood, these create then policies and practices, because those same people that have these biases are creating our institutions and creating our policies systemically within the government, within education, within healthcare. And this history policies and practices then serve to continue to and justify the priming and associations of the implicit bias that we already have. So our current policies and practices create and reproduce these inequitable outcomes that reinforce our implicit biases in a way in which our implicit biases lead us to justify those existing inequities. So if we think that most Black people or most women don't want to work, and we have policies that enforce that bias, they continue to justify these inequities. Some of that is seen in the history of lending discrimination in terms of housing. In the 1930s, there was redlining, meaning they marked racial and ethnic minority neighborhoods in the red, labeling them hazardous to lenders, greatly contributing to the racial wealth gap that is still seen today. In 1968, the Fair Housing Act was enacted to try to mitigate this and protect people from discrimination when they rent or buy a home, get a mortgage, seek housing or assistance. But still, as you can see in 2018, looking at the racial and ethnic composition of housing type, there's still a disproportionate amount of Black and Latino or Hispanic who are in renter households or extremely low income renter households in comparison to their proportion of the population. You can see this mortgage denial rate comparison by race or ethnicity in 2020. And again, a disproportionate amount, 27% Black, 21% Hispanic. Racial disparities and these disparities of implicit bias persist even in our justice system. As we know, racial disparities in prison incarceration rates have been one of discussion as of the last 5 to 10 years. The number of people incarcerated in state and federal prisons are represented on this graphic, and you can see the disproportionate amount of Black people who are incarcerated per 100,000 out of proportion to their percentage in the population. Also, most people in prison are poor, and the poorest are women and people of color. As you can see here, this graphic demonstrates those who are not incarcerated by their annual income, and then incarcerated as well by their racial makeup, demonstrating that these socioeconomic statuses of those who are poor, or impoverished, and people of color are resulting in these disparities within our justice system. Those disparities in our justice system and then in our housing persist into our education. We see that disparities in discipline start in school and they persist into the criminal justice system, with Black students finding themselves overrepresented in those who are suspended out of school, for instance, or overrepresented in those who are in the juvenile justice system for the same offense that continues into the criminal justice system. Even an interesting graphic here in your bottom right corner is demonstrating that even accounting for achievement index. So this is looking at all types of schools, ones that are performing at the lowest and ones that are performing exemplary. There's still demonstration of racial disparities in those schools. So even when you account for everyone being in the same achievement index in terms of education, there's still a disparity across different racial and ethnic groups that persist. In addition to the justice system, we see this in our politics. We see this in our in the way in which people in different communities are suppressed with their right to vote. We've seen this since the civil rights era, when voter registrations are processed late or requested. Mail-ins are not mailed properly during voting, rejecting mail-in ballots, consolidating precincts, making polling locations hard to reach, or even after voting, counting ballots reliably, where multiple places have had to have a recount or failure to have a count properly to cast those votes. This again allows those people, especially in these specific communities, not to be a part of the political system and not to be a part of decisions that can change their socioeconomic status. And finally, this results in a persistent average household net worth gap. You can see this here persisting from the 1980s up into 2019, this gap between white non-Hispanic and Black non-Hispanic continues to persist and not get closer. And finally, all of those things result in housing insecurity, food insecurity, financial insecurity that is disparate amongst the different racial groups, along with educational disparities. So once you have all of these policies and practices that are resulting in these disparities, you then inevitably result in an inequitable outcome and racial disparity. And these are important for us because they show up in our healthcare system. So while we may not see on our daily basis the implicit biases that exist and the policies that occur within society, we do see what that results in terms of the manifestation in our daily lives as providers in healthcare. So racial and ethnic disparities in medicine, despite being in the United States and being in a healthcare system that boasts the existence of cutting edge technology, resources, and research, it's not available to all segments of the population. As a resource, it's tied to social justice, quality of life, and opportunity. Economic well-being is tied to the health status of a nation. So again, going back to that first patient that I showed you, having a patient come in with a stroke in this country and needing stroke intervention, that patient is going to have a remarkably different outcome depending on their race, their gender, and their access to cutting edge technology that exists here in the US, but is not available to everyone. Just a few of the glaring disparities that still exist: infant mortality for Black children remains nearly 2.5 times higher than that for white children. The life expectancy of Black men and Black women remains at nearly one decade fewer than their white counterparts. The diabetes rates are more than 30% higher than Native Americans and Latinos than among whites. The death attributable to heart disease, stroke, prostate, and breast cancers remain much higher in Black populations, and minorities remain grossly underrepresented in the health professions workforce. This is demonstrated by some of these graphics here. You can see in chronic kidney disease, Black Americans are 3 times more likely to develop end-stage kidney disease. Black and Hispanic Americans are the highest rate of new diabetes cases in the country. Female Black Americans have the highest rate of obesity, and Black Americans are 2 times more likely to develop a first stroke. Now, while I bring this graphic up here, what is interesting is that when you go to countries that do have primarily African or Caribbean descent, like countries in Africa or in the Caribbean, they don't have the same rate of these chronic diseases that we see here in the United States. And again, it brings to highlight the way in which disparity colors the way in which patients are able to access the healthcare system. While living in a country that has arguably a higher access to cutting edge technology, they have actually worse outcomes than living in other countries that are considered by large to be third world or have less of an access to what we do here. Life expectancy, as I noted before, in Black men and women are still lower, almost by a decade, to their white counterparts. The rate of mental health in Black patients and white patients in terms of their poor outcome, those who are actually able to get treatment. We have increased surgical and hospital-based mortality amongst Black patients and overall in all surgeries. as compared to their white counterparts. They're more likely to have high-risk surgeries as well. Poor chronic health exists in Black individuals who struggle with a higher prevalence of chronic conditions, as we talked about chronic kidney disease, diabetes, heart disease. And then we'll talk a little bit about the costs of these racial disparities in healthcare. Heart disease deaths amongst men and women ages 25 to 64 by race and by family. You can see that even accounting for family income, you still have a persistent, larger disproportionate amount of Blacks with a higher heart disease death rate in both men and women. Infant mortality, you can see that in pregnancy-related deaths, you have 41% of women who have pregnancy-related deaths as compared to 13% of white women. You can see that even with infant mortality being accounting for education and race, that there is still a disproportionate amount of Black babies who are unfortunate victims of infant mortality, regardless of the educational rate. And then you can even see that here in the neonatal and post-neonatal mortality rates by race and ethnicity, with Black children still having a higher disproportionate rate. We see disparities in the incidence of breast cancer mortality. While Black women have a lower incidence, are less likely to suffer from breast cancer, they actually have a lower survival rate when they do. So what does all of this say about racial disparities in society? Hopefully you can see that this is not something that we can ignore, even as well-meaning advocates for our patients, even as patient advocates and healthcare providers that don't have biases overtly, with all of us doing just the best that we can. Our patients are still victims and subject to the bias that exists in society, and it affects whether or not they can even get to you. In healthcare, we have inequitable access to care, racially discordant outcomes, life expectancy, maternal morbidity and mortality. In the criminal justice system, we have disproportionate rates of mass incarceration, use of excess of force in police encounters, in our socioeconomic ecosystem. Those policies, as I described to you, redlining, predatory lending, voter restriction, resulting in unemployment and underemployment in Black communities and communities of color. All of these work together to create systematic disparities that are reflected in various institutions within our society, but most importantly here for us in medicine. And it takes intentional work to combat these insidious influences. Ignoring this results in a perfect storm of 2020. Disparate outcomes of the global pandemic and racially motivated violence converged to form a true public health crisis. So we saw that the COVID-19 pandemic resulted in really highlighting the already pre-existing racial disparities in medicine, with Black people more likely to die from COVID or have long extended hospital stays as compared to their white counterparts, in addition to having racially motivated violence in our society at this time came to form a true public health crisis, resulting in these type of discussions. But how can we make these discussions not episodic, but really intentional? Is realizing that these social and economic factors that I described to you really drive our healthcare outcomes. So that when these things happen, like they did in 2020 with COVID-19, with George Floyd, understanding that these things are not episodic, they're not a one-time thing. They drive our health outcomes, and when those sort of things happen, like they did in 2020, they only highlight what already is occurring. In our society, if patients don't have economic stability, neighborhood and physical environment security, like in housing and transportation and their safety, education, having high rates of literacy, early childhood education, access to food and healthy options, these are all social determinants of health. The social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. This is defined by the World Health Organization. So all of those things that we've just been describing in terms of housing security, food security, financial security, these all determine how well our patients are going to do. It's not about how well we triage them. It's not about how fast I can do my stroke intervention or how well I can identify that they have an aneurysm that needs to be treated. It's how they are being treated within society before they even get to you. Health inequities in 35 to 50% of cases are believed to account for health outcomes by these social determinants of health. Contributions of sectors outside of medicine affect our health outcomes exceedingly more than sectors within medicine. And I think this has to be eye-opening for those who are practicing medicine, whether it be in a subspecialty like myself within neurosurgery or within primary care. We have to understand that even with our best efforts to provide the best care to our patients, it is really a moot point if we're not allowing the patients to even get to this access of care. In addition, health disparities cost us money. Eliminating health disparities for minorities was thought to would have reduced direct medical care expenditures by $230 billion and indirect costs associated with illness and premature death by $1 trillion. Currently, health inequity costs the U.S. healthcare system $320 billion, and if it is forecasted to cost $1 trillion by 2040. Now, while these numbers are astronomical and hard to really fathom, but just understand that there's money being spent simply because people are not having the same access to healthcare that their neighbors are. A very seemingly simple idea, but we are spending money on this. We're spending money on our biases and spending money on our blindness to that bias. Racial and ethnic disparities are associated with excess health expenditures, illness-related lost productivity, and premature death. You can see that here again in this graphic where you can see that as represented by Black African American, they have an excess premature deaths that cost $293 billion, lost labor market productivity, disproportionate amount Black African American or Hispanic Latino, and excess medical care costs. So this is tragic, but again, as I said in the beginning, I'm a neurosurgeon. So why do I care about this? We have to care about the world in which our patients live in, even if we don't live in that world. If I have that patient come in and that patient that I clip their aneurysm does great, and I am able to then have them discharged, but they never follow up, and I'm not able to see them because they don't have a ride to get to the clinic, and I'm not able to see whether they have a recurrence or they have appropriate follow-up. What I've done, all the hours that I spent to study, to perfect my craft, is a moot point if the patient cannot be taken care of in society, meaning that society is the ultimate postoperative care for our patients. And if we're not taking care of their postoperative status, then there's no point in what we're doing preoperatively. Our work as advocates and providers is to make these individuals, make these inequitable conditions visible, and consider the ways in which our programs and services may be designed without sufficient consideration of how different populations are situated to opportunity in our communities and how implicit bias may be playing out in our own policies and practices. And so as a neurosurgeon, especially as a Black female neurosurgeon, once this really kind of occurred and over the last few years, this renewed interest in inequities and in bias within medicine, I really wanted to see what can I do where I am in my own field of neurosurgery. Well, first is really looking at how it affects neurosurgery. And you can see that here in neurosurgical trauma and TBI, statistically significant higher in-house mortality in minority patients versus white non-Hispanic patients, more than double. Black patients are significantly less likely to get a palliative care consultation after a brain injury. In neuro-oncology, with a pituitary adenoma, Medicaid patients tend to have larger tumors at time of surgery, essentially implying a longer time to presentation, associated with lack of access to subspecialties and a higher postoperative complication. Clinical trials. Whites are significantly overrepresented in adult trials for metastatic brain tumors and high-grade tumors, 91% of enrolled patients. And so we are often offering our Black patients or Hispanic patients clinical trials that they actually did not take a part in. And so we don't know what we're offering, if this is actually going to help them in the same way that we've seen in the white counterparts that are actually part of those clinical trials. Therefore, African Americans and Hispanics have disproportionately worse access to high quality neuro-oncology care over time, with subsequent worse outcomes. In cerebrovascular, endovascular, and MISA specialty, lower rates of endovascular therapy utilization has been seen with Black patients presenting with acute stroke. So patients who have stroke, even when you account for demographic in terms of a rural area or an urban area, still have a lower rate of endovascular treatment. A decline occurred in the number of Black patients receiving intervention during the COVID-19 pandemic versus the pre-pandemic more than any other group. As endovascular neurosurgeons, we saw that there was overall a decline of patients who were presenting for stroke intervention. However, this disproportionate amount in Black patients could not be accounted for by any one thing. Black and Hispanic patients presented more frequently with aneurysmal subarachnoid hemorrhage than for treatment of unruptured intracranial aneurysm compared to our white non-Hispanic patients, again, reflecting a lack of access to subspecialties who can actually find this as a before they become an aneurysmal rupture. Hispanic race and Medicaid status was associated with an increased time to treatment for clip or coil treatment of aneurysmal subarachnoid hemorrhage. And again, while we are excited about the cutting edge technology that we're able to develop when we're trying to treat aneurysms, the new ways in which we can treat stroke, it becomes less important if the people who need these interventions are not able to access it. And so not only reflecting in our healthcare outcomes, we also see this reflected in the workforce within neurosurgery. A call to action, a workforce diversity was published in 2020, demonstrating that workforce diversity is necessary to combat the racial exclusion in the US healthcare system. As of 2018, there were 5,645 neurosurgeons in the country, while only 3.8% were Black. In the 100-year history of the Society of Neurological Surgeons, only 4 members have been Black, a prestigious society of invite-only neurosurgeons that exists. Racially concordant data suggests that Black patients benefit from being more able to talk candidly and openly to Black doctors about their diagnoses and initiate return visits. However, it must be noted here, but it doesn't mean that Black patients can only be taken care of by Black doctors, but rather by doctors who are open to their own biases and the potential different needs of their patients. Black doctors have been found more likely to treat patients that are uninsured or covered by Medicaid, and diversity in neurosurgical staff promotes diversity in the study of health disparities in these communities. Progression of Black Women in Neurosurgery is a publication I co-authored discussing the unique intersectionality of being a Black woman in neurosurgery. While there has been a significant stride in women in neurosurgery increasing the numbers, this has not been seen in the same proportion um, uh, reflected in Black women in neurosurgery, reflecting an intersectionality between sexism and racism. The percentage of Black and African American applicants was 92% greater than that of Black African American residents. So meaning that you are less likely to have to get into neurosurgery, even though there was a higher proportion of those even applying. So 10% of applicants versus 5.2% of residents. In contrast to their white counterparts, which was 17% greater than that of the white neurosurgery applicants. And then finally, you can see it in our numbers here, where this represents the different residents across different subspecialties according to race. We have 183 Black or African American males in neurological surgery. And this is as of 2019, there were 33 Black women within neurological surgery. So we have all of this discussion thus far, talking about our disparities, talking about how this is reflected in our society, and then also in our healthcare. But again, it's still a difficult argument to say, why is this valuable to us as physicians? As a driver of cost and reimbursement, our voices are elevated in our discussions we have in our hospital systems. As a provider of a unique set of skills, abilities, and services, our voices are elevated in discussions we have in the communities that we serve. And as humans serving other humans, our voices have a unique perspective into the real-life experiences we witness every day. When we look at that, we demonstrate the value of our voices as physicians, as healthcare providers. We are ones who are bringing in a expenditure into the hospital by taking care of these patients. We are considered to be providers of unique set of skills within our community and therefore are respected. So when we use our voice to highlight the fact that there are these real life biases that exist in our society that are manifesting in poor outcomes for these patients, we are then able to leverage our voice. So a physician's values hopefully are reflected in what we all want to do. We all want to provide excellent care that continues to elevate the way in which patients are diagnosed, treated, and recovered from various neurosurgical processes or in medicine at large. So what do we stand for as a profession? How do we care for patients if we don't care about them? So we cannot confuse the fact that while we put forth our best efforts to care for our patients in our clinics, in our emergency rooms, in our operating rooms, we actually still have to care about them as a whole. And so those are the principles that the field of medicine can use to enrich the quality of care received by all people. So diversity, equity, inclusion in neurosurgery, again, going back to my wheelhouse, we looked at diversity research forum, looking at the benefits of diverse faculty in academic medicine, demonstrates that increasing diversity in academic health centers is a significant component of efforts being made to reduce healthcare disparities in the United States. And the case has been made that equitable healthcare is incompatible with quality healthcare. To that end, increasing workforce diversity is a primary tool in combating that inequity. So what does DEI look like in neurosurgery, for example? We've made great strides in the field and in the field of medicine and neurosurgery, in particular, to increase the number of women and underrepresented minorities in the field. However, the conversation of DEI has to change from what it's been historically, meaning that diversity efforts, while commendable, increase the number of people from different backgrounds. It has little to do with actually changing equity and inclusion. Addressing equity requires a shift in the conversation to a qualitative principle as opposed to a quantitative one. So it's not just important to have another 10 Black residents within neurosurgery this year, or to have an increase within the faculty. How many of them are chairmen? How many of them are program directors? How many of them are in positions of influence to ask these sort of questions? In short, shifting the power and influence in the field directly affects who we hire and promote and what questions we are asking clinically of ourselves and the field around us. So what are these solutions? A call to action that was proposed to an approach to addressing diversity in neurosurgery, creation of an independent organization, the American Society of Black Neurosurgeons, officially incorporated in 2021, of which I was a co-founder, with a mission to improve public health by supporting Black neurosurgeons and enriching the equity and integrity of neurosurgical care. And then, as we did today, actually collecting the data, reflecting the number of Black people recruited and retained in the field of neurosurgery each year. So if we are actually going to be able to identify the problem, we can actually address it. Optimally challenge the field of neurosurgery with annual task-oriented goals to alter the baseline. Reflecting DEI in the face of organized neurosurgery by inviting Black neurosurgeons into spaces of leadership within our organizations, like our American Association of Neurological Surgeons, or the Congress of Neurological Surgeons, are two large organized neurosurgery institutions, and our training programs as chairmen, chairwomen, and program directors. Supporting the work of studying the disproportionate outcomes in neurosurgical pathology within the Black community, like that I demonstrated in neuro-oncology and cerebrovascular. Those studies that I was able to talk to you about are one of very few. So we still need to actually study the disproportionate outcomes so that we can actually address them. ASBN, again, the American Society of Black Neurosurgeons, one in which I founded to improve public health by supporting Black neurosurgeons and enriching the equity and integrity of neurosurgical care. Some of the things we've been able to do over the past couple of years is to support our interns and residents by having periodic seminars, like our annual resident and intern virtual seminar, getting them ready for neurosurgery residency, going to historically Black colleges and universities like Howard University and exposing those medical students to the field of neurosurgery so that they know that it's an option. And then again, looking at the outcomes and supporting earmarked research that looks at disparate outcomes that affect us within neurosurgery, like diversity-related studies or the mass shootings as in the United States as an alarming trend of violence and public health crisis. In 2022, a year after we were incorporated, we were happy to see the class of 2022 going into neurosurgery, 27 incoming residents, which is the most in the history of neurosurgical match. Addressing this milestone addressed for us recruitment and hopefully going forward retention. In the following year, in 2023, we had 13. So it demonstrates that while our work has been good, it's still not done. So I say all this to say, as an example of what I've hoped to do with my role as a neurosurgeon in my own field, leveraging our value to maintain our values as a social activist. So maintaining data that accurately monitors the dose disparities in neurosurgical care and the recruitment of retention of neurosurgical applicants, like in the ACGME or the American Board of Neurological Surgeons, research initiatives to study neurosurgical disparities, setting measurable goals towards improving the equitable distribution of excellent neurosurgical care across all races, genders, ethnicities, and all cross-sections of society. This allows us to leverage our value as physicians, in my case as a neurosurgeon, to promote my value, the values that I hold dear in providing excellent care to all patients that deserve it and that seek it as a social activist. decreasing the gap and disparities regarding the application of neurosurgical care and its advances. So again, leverage is important in understanding our value. DEI can only be as important as it is to those who are important, so to speak. So those who are in places of influence and leadership are going to be really tasked with the role to make equity and inclusion something that is at the forefront of our conversations, so that these conversations become intentional, not just suggestions, and structural change when they are initiated from the top of the leadership chain. Leveraging positions of power and influence within neurosurgery and medicine help bring these initiatives to the forefront and hold them there with purpose and resolution. Ultimately, we are in the business of taking care of patients, regardless of gender, ethnicity, race, or other systematic bias. However, we are subject to the same biases that exist in society at large. We don't walk around with blinders on once we leave the hospital. And so with that said, just like any other measure to improve the quality and integrity of neurosurgical care, DEI, inclusion, diversity, equity, and inclusion should be taken on with a zest, so that it is no longer enough to look good, but we must actually be good. Thank you.
So thank you, Dr. Mbabuike. That was amazing talk. I'm going to open the floor to any questions. If anyone has any questions that they would like to put in the chat, or if they would like to unmute and speak, they may do so now.
Thank you so much for this talk. I was listening to it with my 5-month-old daughter, hoping that although she doesn't speak, she was somehow understanding your words of wisdom. But it made me think, how have you managed to build bandwidth into your FTE to take on all this work? And we hear so much about the sort of minority status physician being asked to carry more in terms of recruitment and committees and all that sort of thing. And it certainly seems like you're doing that. Are you able to get FTE support for it?
That's a great question. Often this has fallen on the shoulders of those who are passionate about it. I consider it a labor of love, but I do think that those who are in positions to talk about this, to really have to push forth this discussion, should have appropriate compensation of their time and efforts to make other people aware of how important this is to our daily lives as professionals within the healthcare system. So currently, I do all the stuff that I've done, especially my work with the American Society of Black Neurosurgeons, after hours, in between hours, and I do my best to incorporate that into my daily schedule. But as I said, it's a labor of love for me. But I do think, as I said at the end, that we really need to embrace diversity, equity, and inclusion with the same zest that we do with other markers of health outcomes.
I have a question as a medical student perspective.
Mhm.
Just what would you say are some of the best ways that medical students and residents can help combat these inequities at our trainee level?
Yeah, that's a great question. And I do think that everyone can contribute at the level that they're at, whether you be an undergraduate student, or medical student, resident, or faculty, and anywhere in between. I think it's important to ask the questions that I brought up towards the end, and in particular for neurosurgery, or wherever you are. How are we addressing the biases that may exist in this medical subspecialty that I may be in? Say, even as a medical student, how are we addressing those who are even able to access the same medical education that I am? Are we talking to undergraduate students? Are we creating pipeline programs? As a resident, supporting research that looks into how your patients are doing according to race, ethnicity, gender, different socioeconomic statuses. Asking those questions allows those questions to be answered.
Thank you. And there's a question in the chat. I want to know, how do you approach colleagues that have been exhibiting implicit bias towards patients?
That's a great question. And I think it's become an easier task, fortunately and unfortunately, since 2020, in that prior to that, it was really taboo to speak about bias and to speak about the potential existence of it, especially in the healthcare profession. But now that we are open to a more open dialogue, the best way in which I would want to approach someone who I've noticed has demonstrated evidence of implicit biases, again, going back to the slide that I had on blame and responsibility. Approaching someone, especially a colleague, in an accusatory manner, really defeats the purpose of hopefully what your end goal is, which is to educate and to make them aware of a bias they may not be aware of. And so instead of blaming them for maybe their bias or what they exhibited, you really approach them from a manner of what's our responsibility as physicians. Even if I have for an example, a partner who's taking care of an African-American patient that I know is maybe not getting the same treatment that I've seen them give another patient. I asked them about that. And rather in an accusatory manner, but in one which, did you notice that you did this? And that patient probably needs this in a way that you didn't see. And really approaching it from a point of education shifts blame and allows them not to feel shame, but responsibility to do better.
I
Go ahead.
Hi, thank you, Dr. Mbabuike, for your talk. So I'm a second-year medical student, and I am very much interested in neurosurgery. I'm at Tulane, actually, and the difficulty for us is we don't know anybody like us, right? I don't have family in medicine. I don't know people, and I didn't know people in medicine until I got here. And now that I want to do neurosurgery, I don't see people like me. And one of the struggle was also finding mentorship guidance. How do I go about this? How do I bring visibility to myself? And also, how do I get people like me interested in the field as well? And how do I keep going and really stay encouraged despite the negative comments that I hear everywhere, truly?
Mm-hmm. Well, great choice. I commend you in wanting to pursue a field that is very rewarding, but definitely challenging and requires a lot of sacrifice. Like you, when I came into it, I did not see a lot of people like me. Part of the purpose of forming the society, the American Society of Black Neurosurgeons, was to hopefully have people like you see those who look like themselves interested in neurosurgery and see that as a possibility for yourself. So the American Society of Black Neurosurgeons is a great resource. One, in our seminars, in getting contact with other residents, faculty neurosurgeons who can be of assistance in providing you feedback as to where you are and what you'd like to do, and helping you in any way that we can. The purpose of it is to be what I would have wanted at your level. So if you go to amsobns.org, you'll be able to, there's a join us link, and you'll be part of our mailing list. And then also you can, there's a portion there where you can sign up for our mentorship program.
Thank you so much. I really appreciate you. Thank you.
Absolutely.
Hi, I'm Michelle. I'm a current resident of Tulane neurosurgery. Um, I was interested in first of all, thank you for this talk and all the work you're doing. But I was interested in the point you made about the stroke thrombectomies and getting less, or just that intervention is underutilized in the Black population. Is that mostly from an access perspective, or is it actual like selection bias in the patients that are coming in? Either due to implicit bias or due to maybe those patients having more comorbidities, or I guess, could you maybe delve into that a little bit more?
Yeah, so again, the question, was raised as to why this is occurring. So when you actually accounted for their access, so patients in the same area as their white counterparts. So it didn't matter if they were rural, didn't matter if they're a more metro area, accounted for the same, because stroke intervention is often going to be guided by their time to presentation, and guided by what other comorbidities they may have, and how bad they are at presentation. Even accounting for all of those, they were less likely to be offered stroke intervention. And so we don't know why that is, because even when you account for access, okay, same place, you account for comorbidities, account for the stroke scale at their time of presentation, they're less likely to be offered stroke intervention.
Okay. Thank you. I wasn't aware of that. Not surprising, sadly, to me, but definitely appreciate learning that. And then to the med student who just spoke, I can try to. I'll message you. I've reached out to Dr. Johnson is one of our endovascular specialists. I sent him a screenshot like, hey, I'm listening to this talk, and he said he had met you and he was interviewing at some point. But he said he's trying to get something off the ground with research with respect to some of this stuff. So hopefully we can do some good work in the future.
Hi, okay, I'm also a medical student from Tulane. I'm applying for neurosurgery. We're currently in the application cycle. You've seen my name on some of the emails, I think, back and forth for this talk.
Yeah.
So one of the things that I was really struck by is your commentary about how society is part of the post-op care. And I wanted to run something by you that I've seen, at least at pediatrics here in my clerkship. One of the things I used to do for patients that say didn't have access to a car, and that was like actually a really debilitating aspect to going and getting pediatric care, right? They would actually get Ubers for their patients to help get them to and from the hospital. And I was wondering, from a neurosurgical perspective, would that be something feasible? Could we do something like that for our patients that might need access in that way? I don't know exactly what that route is to go there, but I just kind of wanted to feel what you thought about that.
Yeah, I mean, I think, but those are the questions that need to be asked. It's the same question where, I'll give you an example, patients who have brain tumors that require stereotactic radiation, and that requires multiple cycles, and they do not have the ability to come back and forth. And this affects the way in which they are then going to approach adjuvant therapy, chemotherapy, and radiation. They literally do not have the transport. Ignoring that issue really puts us at a disservice to just say, oh, these patients are just not doing well from glioblastoma or from whatever neurosurgical pathology they're being treated for. But why? So it's not just that these patients are inherently going to do poorly from glioblastoma, but there are reasons why they're not doing well. So while we make these advancements in the way in which we can treat them with stereotactic radiosurgery, chemotherapy, and even with operative surgery, if they're not able to access it, if they're not able to fully utilize the opportunity, ignoring that really does them a disservice, and even poses the question, why treat them in the first place?
Thank you.
I had a question kind of piggybacking off of that. So I'm a second year med student at LSU, and I work a lot with the student-run community clinic. So we served a lot of unhoused individuals, and we see a lot of patients that need neurosurgery, right? But it is a task to get those people to come to the clinic in the first place. But then adding the whole like neurosurgery seems like this big scary thing when medicine in general is already scary. How can we, I guess, help change that narrative for these patients that we see that are already like have had these terrible experiences with medicine and get them the care that they need?
Well, I think that's a great question. And even just asking the question is a great start, right? So you're noticing this and noticing it not as a patient who doesn't want to participate in their healthcare, but doesn't know how. And the best way in which that I think to approach these patients, especially those who are intimidated by the system in general, is with education. As part of a comprehensive stroke center, where I was prior to this, in trying to build a comprehensive stroke center within a community, community-facing patient education was very important. Because they become then advocates for themselves, and then they come in asking for the things that they need. So they know that these are things that are available to them, that these are things that could help them. So they know that, hey, I've had a stroke. It doesn't mean that there's nothing to do. It means actually, if I can get to this center in this amount of time, they can actually change my outcome. And that's an educational standpoint that a lot of patients still don't have. Understanding that if I have a tumor, like this is something that I can actually have operated on and I actually can do well from. That there are ways that I can work with either a social worker or case management to get me back and forth to my radiation treatments. So education is really important to patients, for patients to understand what their experiences can be versus what they think it will be.
Awesome. Thank you so much.
No problem.
Right. If there's any further questions, how would you like people to reach out to you, Dr. Mbabuike?
Yeah, again, thank you to everyone who's tuned in today. I hope you learned something. I hope you had a little nugget of what I was trying to have come across as the perspective from a neurosurgeon. If you have any further questions about the talk or anything in general, I am open to mentorship and open to really guiding people who are interested in medicine in general, neurosurgery, and more specifically. My email address I can put in the chat, and that is going to be the best way to contact me. And I'll get back to you once I get that message.
And thank you so much for sharing your time today. I'm sure everyone here is going to walk away with that in the forefront of our mind, keeping that responsibility of being aware of all of this and asking questions and doing our best to be involved. So thank you, Dr. Mbabuike.
Very good. Thank you for having me, and have a good rest of your day. I'll put the email address in the chat now.
So thank you.
And I also put our website, the American Society of Black Neurosurgeons, in case you're interested as well. Have a great day.
You too. Thank you.
Bye.